Without further ado, let's get started about contrast enhanced ultrasound. So I have no financial disclosure. Sometimes I think I should get paid by Bracco to give these talks. I talk about this so much. The other disclosure is that at almost all of these talks, they talk about how they're going to discuss off-label uses of ultrasound contrast agents. And I guess that's important, but we do so much in pediatric radiology that is off-label that I'm just going to stop saying that one of these days. But we are going to talk about IV applications of contrast enhanced ultrasound, if that's okay. I find the other applications where you just inject it into a cavity and see where it goes less fun and interesting. So IV indications. We'll talk about ultrasound contrast agents and basics of contrast enhanced ultrasound. We're going to focus a lot on liver lesion characterization because that's the most common IV application, and then we'll spend a little bit of time on other uses. So there are a lot of contrast agents in the United States that one might be able to use for doing a contrast enhanced ultrasound. By far and away, the most common in pediatric imaging is the top one, Lumason. In the United States, it's called Sonoview. In other countries, just the way it's marketed. And the real name, the generic name is sulfur hexafluoride lipid type A microspheres. And the reason I always use the trade name is because it's so much shorter. So I hate using brand names usually, but not in this situation. The good thing about Lumason is that it's the easiest to use also. You get beautiful enhancement or perceived enhancement. You don't have to refrigerate the contrast agent, which if you have to refrigerate a medication in radiology, there's a lot more hoops to jump through. So like monitoring the temperature, recording the temperature, stuff like that. And then you just hand inject the solution to be able to reconstitute to make the contrast up. That's unlike Definity, where you have to have this little shaker thingy that it's like a little miniature paint can shaker that you have to be able to mix up the contrast for yourself. Optoson, you have to put a little mini spike in the vial to be able to vent it to then draw it up so you don't burst the bubbles as you're drawing them up. And then I just wanted to mention, since there's more and more literature in the adult world coming out about Sonazoid, it is a newer agent that has, it's interesting. It works a little bit different because it has a Kupfer stage of imaging. So when you're interpreting images with this contrast agent, just keep in mind the lesion enhancement characteristics will change with that agent. So again, just more about sulfur hexafluoride lipid type A from Bracco. It is FDA approved for IV administration for liver lesion characterization in pediatric patients of all ages, so 0 days old onward. And there's really not much in radiology that is approved through that young age. It's also approved for echocardiography, but they rarely need contrast to do pediatric echoes. And then obviously it's approved for VUR evaluation for contrast enhanced voiding ultrasonography. The dose that people use is somewhat variable. The package insert or the approved dose is 0.03 milliliters per kilogram, which gives you, anywhere from 0.1 to the adult size dose of 2.4 milliliters. You'll read in the literature that some places will use like an age-based, just sort of bulk dose that they give, but we will still calculate the dose that we give based on weight. And then one other thing that sometimes is a little bit confusing, there used to be on the package insert a contraindication to not use some of these agents in the setting of cardiac shunts. And I think that some people maybe interpret that as it might change the enhancement characteristics, but it was a theoretical safety concern, and that contraindication is no longer present. So patients with congenital heart disease, infants with patent ductus arteriosus, whatever, it's okay to give that stuff. The only contraindication in this day and age is allergy. And just one point about allergy, there is some theoretical cross-reactivity with the agent that's in Miralax. So there really aren't that many patients with a true Miralax allergy. But if you have a patient that has a Miralax allergy, just be careful giving Lumason to those patients. We always have a contrast reaction kit anywhere that we give contrast, including in our ultrasound suites. Just a little bit more about these agents. So Lumason in particular has like anywhere from 1.5 to almost 600 million bubbles, micro bubbles in 1 ml. So we get beautiful enhancement because we're injecting so many bubbles. The shell is a fat and lipid shell, and then the inside is an internal inert gas. And the shell has hepatobiliary excretion, and the gas is exhaled. So there's no renal excretion whatsoever. You don't have to have any functioning nephrons to be able to safely get these contrast agents. The contrast agents, each little microbubble is smaller than a red blood cell, but I think of them like a red blood cell. So they pass through the capillary bed without diffusing into the interstitial space. When they hit the lungs, they are exhaled, but it's not 100% first pass clearance. And so you will get left-sided circulation enhancement with these contrast agents, which is why the contraindication in patients with shunt really doesn't make too much sense. Just a couple of other brief things about physics, because the way this works, the software on your ultrasound machine is going to do a couple of things automatically when you turn on your contrast presets. So the first thing that it's going to do is turn on harmonic imaging. So it's going to send a wave that's kind of stronger and kind of less strong, if you will. And then the background soft tissues, when they get hit with that ultrasound pulse, expand and contract the same amount. These bubbles expand more than they contract over time with the harmonic ultrasound wave. So when you sum those echoes, your background soft tissues should be nulled, so completely saturated out, whereas you're still going to be left with the echo from your microbubbles. So before you give contrast, you really shouldn't have any sort of enhancement whatsoever on your, most machines will give you a split screen image where you have a grayscale image for kind of landmarking to make sure you can see where you are, that you're like at the site of the anatomy in question. And then it'll have a contrast only screen, which is that subtracted image. So you're just getting the microbubble enhancement on that screen. And this is what it looks like post contrast. So all of the bright structures are going to be the microbubbles within tiny or large blood vessels. So in this case, we have IVC, and we can see our hepatic veins as well as the tiny little microbubbles in the hepatic parenchyma. A couple of other things to keep in mind. So you'll notice the grayscale picture on our dual screen monitor was pretty ugly. Like we would expect much better image quality in small pediatric patients. And the reason for that is you have a low mechanical index so that you don't burst your bubble. So remember, as you're using harmonic imaging, these bubbles are expanding and contracting, and you don't want the bubbles to burst or you will lose your enhancement. There's also a low power output and a low thermal index. I always say that the microbubbles resonate best at lower frequency, but not too low frequency. So the optimum resonance of these microbubbles is like 2 to 6 megahertz. Sometimes in pediatric imaging, we can run into issues with that, because if we can only see a lesion with a linear high frequency transducer, when we switch to a mid frequency or lower frequency transducer to be able to see the enhancement the best, sometimes we'll lose visualization of the lesion in our landmarking image. So some trade-offs. You can typically, I will choose a higher frequency linear transducer and just kind of lose out on the optimal enhancement. I don't know if either Jeffrey or Haitui, if you have do you have a preference on what you do in that situation?
Yes, that's interesting that you mentioned. I didn't really realize the physics behind it, because I usually do use the linear probe when I image bowel, just because, you know, the bowel walls and everything looks so much better. But I haven't found the enhancement. I guess the only ones I refer to as are really sick or abnormal bowel. So a lot of times it doesn't enhance as much, but I do compare it to other things just to make sure that it's not just related to technique, because we do look at vessels and stuff like that nearby too for comparison purposes. And then those are resected or not. So yeah, to your point, I don't know if I had I used like a curve, like would the bowel enhance more than with the linear. But usually with liver lesions, I tend to stick with the curve.
I agree with you. Usually what I try to do is if the lesion is in an amenable location, I'll try to do one injection with each probe just to kind of get a different look at it, just to see which one works better. You know, sometimes we'll try the curve and it doesn't look great, then I'll switch to the linear, because we always have the second injection. Even if we're just looking at a single lesion, we always if we get a good look at it with the first injection, I'll almost always take advantage of having that second injection and just tweak a couple things, either try a different probe or try some different window or something just to get a different look at it. But overall, I agree. I generally prefer the linear as well.
Yeah, that's a super great point. We are allowed in FDA, like per the FDA approval, 2 injections. And what's interesting is I don't understand the physics completely, but the second injection, there is always better enhancement. It's like one of those things that I don't quite understand why that happens, but yes, I don't hesitate to give contrast twice for sure. Okay. At our institution, we are so lucky that we have dedicated pediatric nurses in our radiology department because we do contrast enhanced CTs and MRIs all day. And so we have the benefit of having a separate little area where our nurses can place IVs. I try to get them to place the IV not in my ultrasound suite if possible, especially for younger kids, so that they don't associate the IV placement with the ultrasound or the contrast enhanced ultrasound. At our institution, we will use any sort of IV access that they can get. So we don't have any size constraints, and I'll talk a little bit more about that on a couple of slides. We do still need 2 staff to be able to do these studies. So 1 person is going to scan, and then 1 person is going to inject the contrast. And again, the dose that we use is 0.03 milliliters per kilogram, because we always have a weight, and so we just give the weight-based dose. So more questions for you guys. Who injects contrast at your institution? Do you have a staff radiologist who is involved with giving contrast, or who does that for you guys?
So at CHLA, it's staff radiologists. And I guess a follow-up question to that is, and of course, the radiologists in training or any kind of trainee, if they're with us, then sometimes we'll allow for the injection too. But do you guys have like a select group, or does everybody in your guys' groups do the injection or perform it or read it?
I'll answer that. We only have a handful of us who are willing to. I should maybe not willing, because a couple of my colleagues don't really want to do these, but they will do it because I'm not there every single day. We are training our fellows for how to administer the contrast. And we started that last year, actually, because our practice is a little bit different. We have several radiologists who are exclusively located off-site, so they physically cannot be in Pittsburgh to be able to give this contrast. So eventually my goal is that I'm going to have the sonographers give the contrast. Just like with CT and MRI, it's not a radiologist or a physician at all who gives the contrast, although we obviously approve the dose. So that would be my goal one day.
Yeah, no, it's definitely an interesting kind of logistical hurdle to kind of figure out how to address these things. So for us, as far as the injection, it's a little bit different whether it's a kind of routine scheduled outpatient versus an inpatient that we're doing portably on the floor. Most of the time, if we do them as scheduled outpatients, we actually do them in our IR area just because that's where our nurses are located. So we walk over there with a sonographer, and then the nurse is present. So the nurse, the nurse is usually the one who does the injection. I've done a couple on the floor where I personally have done the injection, and the floor nurse is kind of just there to help with whatever, but it's usually just myself and the sonographer. As far as who is actually doing these examinations, when we first started, we had just a few sonographers and a few radiologists that were kind of the ones that were quote unquote approved to do these examinations. And it was really a challenge from a scheduling perspective. Just, the schedulers had to look up, which sonographers were working, where they were working, which radiologists. And it ended up, I think, kind of pushing us away from doing these examinations because, hepatology would order them, and then it would be like 2 months before we could get them on the schedule, just with all those moving pieces. So we ended up moving, at least for the liver lesions, we have it. So now that any sonographer and any radiologist can be involved in those examinations. And I think that's worked for us at this point. They can always ask, one of us that's more comfortable with interpreting the examinations if they need to, but they can at least kind of be present and help kind of triage the logistics of actually completing the examination. For some of the weirder indications, the more off-label stuff, those end up going to me a lot of the time. So So those are kind of the same thing. We run into the same kind of scheduling issues just because I have to be there. But I think overall, if you can make it so that as many people as possible can be comfortable with doing these examinations, I think that's really to the benefit of just making it as smooth as possible to schedule and get these exams done.
And do you only do them a certain day a week, or do you offer them any day a week that the patient wants to schedule them?
We basically say any weekday during kind of business hours, 8 to 5, and only at we have our Anschutz and our Colorado Springs campuses. We have a couple kind of smaller satellite campuses that we have not started doing this area yet, because I think that's a whole nother logistical challenge. But at those two sites, just during weekday daytime hours.
Yeah, we also have lots of satellites, but luckily or unluckily, we don't have the contrast software on those machines that are located at those sites yet. So we haven't had to decide what to do in that case yet, but I'm sure one day that will change. Okay. Great discussion. Thanks. Okay, yeah. So back to the IV. So we use basically any IV that the nurses want to place or that the patient already has existing, including like teeny tiny little neonatal picks. The one caveat that I don't love to use is ports, because the contrast agent sort of like encounters a bunch of mechanical and shear forces inside of the port hub before it goes into the catheter to be injected. So I've personally experienced lots of suboptimal enhancement when we inject through a port. So if I can inject somewhere else, I prefer to do that. The reason I think that the adults always recommend 20 gauge IVs is because they do a lot more quantification and studies where they will use software to count the number of bubbles that they use, which for us, we do a lot less quantification work than I think is described in the adult literature, which is my next question for you guys. Do you routinely post-process? Hey, Tweet, it sounds like you do bowel with some frequency. Do you routinely calculate or generate time intensity curves for those patients?
Yeah, I do. And I mean, there's lots of issues with it. So that's kind of the reason why I propose this question. Because I mean, even though it's quantification, it's not like perfectly accurate, and it varies between different vendors and stuff. But I feel like when we follow patients over time, it's nice to have like just numbers, and then who knows if there's anything to glean on it, in the future. So I do try to post-process a lot of my exams. But the caveat is we're not that busy as far as like volumes. So I would imagine if, we had like tons or a lot more like you guys, then we may not have the manpower to do so.
What are you just using the software that comes with your machine to be able to do that?
Yes.
Yeah.
So it's only if, we're not like back-to-back scanning, and I do have the time to kind of do the post-processing, but it doesn't take that long, I guess. So it's worth it just to have and then look back onto.
Yeah, we are not. It's definitely an interesting concept, but it's not something that I have explored in Colorado yet. I'm really curious. Like, is this automatically built into your machines? It's like a separate software package you have to buy, or how's the logistics of that actually work?
So for us, it's part of the software package, the contrast software package.
Okay.
But I will say it's not particularly user friendly, and for me, the information is less helpful than. So a lot of the studies you read will either use homegrown software where they export the images and data to separately quantify stuff and get absolute values, absolute decibel levels, or they use something called, what is it called? I'm blanking. ViewBox, I think it's from Bracco, but you can't actually get that in the United States unless you're like a big time researcher on the adult world typically, because it's not approved for non-animal research anything. So that's like a huge, I would say, area that really needs to be worked on in the contrast enhanced ultrasound community, because every time I submit a paper that has to do with contrast enhanced ultrasound, they ask me about quantification, but there's not great quantification out there for a relatively small time researcher like me. You know, the software that comes on our machine gives me a log scale. The numbers sort of change over time. So even for bowel imaging, where I want to follow this segment of a patient with Crohn's disease or whatever, the absolute peak intensity will vary regardless of if the disease has changed, I feel like. So definitely frustrating and an area for improvement. If anybody's out there who wants to market their software. Okay. I was going to go over a bunch of examples now because I think this is like the most fun part of contrast enhanced ultrasound. And for liver lesion evaluation, it's important to keep in mind that what we do in kids is different than what we do in adults. So in adults, oftentimes what happens in the contrast enhanced ultrasound world is they're screening patients with cirrhosis who are at high risk for hepatocellular carcinoma. And in kids, that's not typically what we're doing. So in kids, we usually have some sort of an incidental liver lesion that we're trying to characterize that we've found on either ultrasound or some other imaging modality. In kids, HCC is different from adults with HCC. There's no screening guidelines, not like exist in adults anyway. There's the ACR-LIRADS criteria in adults. In pediatric LIRADS, there is a committee, but the diseases are far too heterogeneous to be able to come up with great screening guidelines for each disease. We know that the ACR-LIRADS criteria that they use in adults are less helpful in peds. And we also know that most children or teenagers who have hepatocellular carcinoma don't have underlying cirrhosis. So lots of problems. So we're dealing with a different patient population than what you'll read about in the adult studies or with the adult ACR contrast enhanced ultrasound like guidelines. But we still have adopted a lot of what they do in adults because what we are doing and what we're trying to characterize is kind of similar. So how do you do the contrast enhanced ultrasound for liver lesion evaluation? You want to get the wash-in appearance of the arterial phase in a cinematic clip, because sometimes it happens so fast that you have to go back and watch frame by frame that enhancement characteristics as it washes in. And then so in the arterial phase, this is where you want to keep the patient still. So we obviously are not going to sedate a child to undergo a contrast enhanced ultrasound, but we are going to distract as much as we can. So I've had patients nursing, I've had patients watching iPads, I've had patients with child life in the room, you know, like distracting the kid during the arterial phase, because in the portal venous phase, you intermittently scan, you refine the lesion and see what that lesion is doing compared to the background liver parenchyma. And the reason why you intermittently scan is a problem that we run into, especially with our linear high frequency transducers, and that's burnout. So the transducer itself is bursting the bubbles in the near field, which can be confusing if you're dealing with a superficial lesion. So is it just burnout from the transducer bursting those bubbles, or is it actual lesion washout? It can be challenging. So again, kids are not adults, and the lesions that we have in pediatric patients are going to be different from the charts that are ubiquitous in the adult-based literature. Number one, they use hemangiomas, which yes, I am going to harp on hemangiomas and the differences in pediatrics versus adults again. We know that there are lots of different subtypes of adenomas, and so when you look at the adult contrast enhanced ultrasound literature, they're starting to tease out the different subtypes of hepatocellular adenomas, but there's more work to be done there. And then HCC, thank God, is rare in the pediatric patient population, and cholangiocarcinoma is incredibly rare. So we have different lesions in pediatric patients, and the differential diagnosis will vary obviously based on the age of the patient and how they present. So it is somewhat helpful with contrast enhanced ultrasound to dichotomize based on the washout phase. So you get the arterial phase wash-in appearance, but then you start to characterize the lesion based on the washout appearance. So if there is washout, if there's no washout, then the arterial phase becomes super important, because the enhancement characteristic is going to help you definitively diagnose what the lesion type is. If there is washout in the delayed phase, usually that means malignancy, but we have more lesions in the pediatric patient population that wash out that are benign compared to adults. We'll talk about those. If you do have washout, that's when it becomes important to ask, okay, well, what kind of washout? Is it subtle? Like I have to squint and like window my machine width and level to be able to see it? Or is it marked? Like I'm standing at the back of the reading room and I can tell, yeah, that's definitely a lesion that is washing out. The lesion is darker compared to the rest of the liver around it. Then you ask yourself, when did it wash out? So was it early washout, as in within 1 minute, or is it late washout, like 5-6 minutes? So the background liver is starting to sort of wash out, but the lesion is subtly starting to wash out before the background liver, or is it in between? So examples. So this was a 3-week-old female who we didn't actually recommend the spine MRI. It was done at an outside hospital, so I don't have that spine MRI to show you the lesions, but we did go on to ultrasound and contrast enhanced ultrasound. So you can see multiple, at least 2 in this one image, hypoechoic liver lesions, so obviously indeterminate just based on this image alone. At contrast enhanced ultrasound, I love this cine clip because the enhancement of these lesions is so rapid. We have complete enhancement of both the lesions and the background liver before 15 seconds post-contrast. So just some stills showing that in slow time. The reason I love this is because typically when we are doing a multi-phase CT or multi-phase, like a dynamic post-contrast MRI, we don't start imaging in the arterial phase till after 15 seconds. So this lesion we probably would have missed on a biphasic or triphasic, depending, CT. Not that I'm advocating multi-phase CT in an infant, but if somebody was to do that, if they didn't have the ability to do MRI. This was one of the first lesions I did where there was washout. I was like, well, these are going to be infantile hemangiomas, but there's washout. So this is where I say that sometimes washout means malignancy, but it's less of a slam dunk in the pediatric population compared to adults. So infantile hemangiomas, we talked about this last week, but just a reminder, infantile hemangiomas are going to be multiple or innumerable. They have early arterial enhancement, typically out to in enhancement. They are going to have sustained enhancement, hyperenhancement, or washout. So the clinical picture is super helpful here. And the lack of early washout is helpful because what's your differential for multiple liver lesions in a pediatric patient? Metastases. So although infantile hemangiomas can have washout, they do not have early marked washout. They have late subtle washout if they wash out. So important distinction. Our next case is, you guys interrupt if you have questions, please. This is a 14-month-old who we thought it was a congenital hemangioma, but it was not involuting. And so you can see the sort of weird like donut-shaped lesion in the posterior right hepatic lobe. At contrast enhanced ultrasound, it had similar characteristics to the infantile hemangiomas I just showed you, a little bit slower wash in, but it still has that out to in enhancement pattern. And you can see this patient is moving, this patient is breathing, but you can still see the lesion really pretty well, despite losing it every once in a while. Just some stills showing you that sort of out to in pattern. There was some absent enhancement centrally of this lesion. And I think that's because this was an involuting congenital hemangioma. So when you look at this delayed phase, so look at your background liver parenchyma, it is losing contrast enhancement, but we still have enhancement of those areas that were enhancing of our lesion here. So this is a congenital hemangioma. So congenital hemangiomas, just to review, are solitary lesions. They, the imaging characteristics are like what is described with hemangiomas in adults. So out to in enhancement, they can have either complete or incomplete enhancement depending on the amount of internal necrosis or hemorrhage or whatever else is happening on the inside of these lesions as they involute. We do know that some washout is possible, but I'll compare that to what you would expect with hepatoblastoma on a few later slides. Now this is keeping on a theme, but this one is an older teen, so not an infant, who had an incidental liver lesion. And this again has that globular out to in enhancement pattern, no washout. So this is what we should call a venous malformation or a vascular malformation, not a true hemangioma. But the enhancement is similar to both congenital and infantile hemangiomas. So just quickly, a fast review of our vascular anomalies. What we call hemangiomas in adults are not actually vascular neoplasms. Those are vascular malformations, and they're usually venous malformations. There's some confusion based on the old WHO classification of hemangioendothelioma versus congenital hemangioma and infantile hemangiomas. And really, when you're talking about hemangioendothelioma in this day and age with the ISFA classification, you have epithelioid hepatic hemangioendotheliomas, which are adolescents. Those are older patients with multiple lesions that have a different appearance. They aren't vascular like these hemangiomas are. And then composiform hemangioendotheliomas are not typically hepatic primaries. They can involve the viscera and then invade into the liver, but it's a completely different look from these congenital hemangiomas that would occur in the liver. So the vascular neoplasms, which is why these lesions can have washout, is because they're neoplasms, right? They're benign, but they're infantile and congenital hemangiomas. And I had a resident ask me once, well, who cares? Like, why do we care about the difference between these? So congenital hemangioma on the left at MRI, and then infantile hemangiomas on the right. Why do we care? Because the treatment matters. And my vascular anomalies team wants me to say as specific as I can. And so I try to, because the treatment changes. So with congenital hemangiomas, they might try to coil somebody if a patient, if there's a lot of shunting and they're symptomatic, but they might, usually we do nothing for those. Whereas infantile hemangiomas, they'll treat with propranolol if they need to. Okay, changing topics just a little bit, still on the liver lesion topic. This was a 10-year-old female who had non-alcoholic fatty liver disease, and they found a lesion at the outside institution ultrasound, which they performed for concern for NAFLD. And this one is my favorite lesion and the lesion we see most commonly. So it has this sort of spoke wheel enhancement pattern, looks like a wagon wheel, sort of in to out enhancement. And in the delayed phase, where we would expect to see washout, the lesion held onto contrast compared to the background liver parenchyma. So this is the focal nodular hyperplasia. So I tell my residents, it's like a firework. They're so excited. It's not cancer. It's like the 4th of July. These fireworks go off. I also like the firework example because FNHs, focal nodular hyperplasia, can have a feeding vessel. So just like a firework will have the streak of the firework going up, followed by the in to out explosion, the feeding artery of a FNH might be seen. These typically have sustained enhancement. The vast majority of them do. We have seen some washout, which can cause confusion. And typically those patients will go on to MRI to confirm. They might need to go on to biopsy if the MRI is not helpful also. So don't forget to use all of your resources to be able to characterize these things. They, just like other modalities, they can have a central scar that's non-enhancing. And then just a quick plug, if you have a patient with underlying liver disease or some other injury that happens, so chemotherapy, cancer survivors, we call those FNH-like lesions, but the enhancement is similar to focal nodular hyperplasia lesions. Okay, changing gears just a little bit. So this was a 15-month-old who had end-stage renal failure. We have a liver lesion incidentally seen on a renal ultrasound. I'm going to show you the arterial enhancement, even though it's not helpful. So this type of lesion can have hypervascularity. It can be hypo-enhancing compared to the background liver. But what matters is what happens in the washout. So in this case, we had relatively early, but not very early. So it was after 1 minute where the lesion lost enhancement compared to the background liver. So this is a hepatoblastoma. This patient, because he had end-stage renal disease, could not undergo MRI. And so on the CT, these lesions are incredibly subtle to be able to see. He went on to staging CT, which is what you should do in the setting of hepatoblastoma, because you need to be able to give a pretext or a pre-treatment extensive tumor stage for these patients. So again, the arterial enhancement pattern is variable. That doesn't matter in these patients. What matters is the washout. And just to compare, because I said I would, so compare these cases of, on the left, congenital hemangioma. So you have a solitary lesion. Hepatoblastoma is your primary differential in an infant with a solitary lesion. But in the washout, you're either going to have sustained enhancement of the entirety of the congenital hemangioma, or the case on the bottom, there was a little bit of central washout, but we still had a lot of enhancement of the peripheral aspect of the congenital hemangioma. The hepatoblastoma, by comparison, is diffusely, heterogeneously more washing out. So, there's like a lot more necrosis, a lot more irregularity. The appearance is just different, I think. So some people are like, I can't tell the difference between all of these types of washout. And yes, you can. It's not that hard. You guys can do it, I promise. Okay, so that's my liver lesion evaluation talk, and these charts are all available online for you guys to find.
Judy,
I was going to move on to other indications.
oh, just briefly, I had a question from the audience.
Yeah.
How can you convince your oncologists who feel strongly that EUVIS is the gold standard to trust CEUS to characterize liver lesions? And then do you have to do both exams in each patient for a while before they feel comfortable, or?
So I have a couple of advantages, competitive advantages, if you will, in my group. So I'm the tumor board radiologist, and so I would recommend what I would feel to be the best study. So I wasn't always saying EUVIS, I wasn't always saying contrast enhanced ultrasound. And I had already built a good deal of trust with my clinical colleagues to be able to say, I think we should do this versus that. The other thing is, once they have patients who have had both studies, patients really prefer contrast enhanced ultrasound definitely compared to CT. But the clinicians know that there are potential deleterious effects on the developing brain with sedation, which a lot of their patients have anxiety related to imaging, so their patients may or may not need more general anesthesia or sedation to undergo MRI. So I'd just be insistent that, obviously recommended appropriately. If it's a patient you don't need to do, further confirmatory imaging on, don't do it. If it's a patient who would really benefit from an EUVIS, so multiple liver lesions, the liver lesions look different at ultrasound, or you're going to need to go on to staging CT or MRI, depending on what your practices are at your institution, do that. The other thing that's been helpful for me is be confident. So, it's not helpful when the clinicians get a read that, like on an MRI with EUVIS for a liver lesion, yes, you'll have atypical lesions. So like HCC can have EUVIS retention, but I think it was helpful that a lot of times the MRI read would be most likely this is, this benign lesion. However, well-differentiated HCC cannot be excluded. And I don't give those reads on contrast enhanced ultrasound. I try to be as helpful as I can. So, yeah.
Have you ever tried to use pretext on your contrast enhanced ultrasound?
So one thing, you have to have a chest CT for the lung metastasis evaluation. We have definitely answered questions following either a CT or an MRI at contrast enhanced ultrasound. So, it was like a poorly timed CT, or there was an issue with whatever at either the CT or MRI. And so rather than repeat the CT, we've gone on to contrast enhanced ultrasound. We've also done a couple of intra-op cases where they're going to do a non-anatomic resection. So like a little pedunculated lesion off the right hepatic lobe is the one I'm thinking of. We gave contrast in the OR so that the surgeon was more confident in where his margin needed to be. So I still advocate for MRI with EUVIS for tumor, especially for the tumor focality question. Much prefer MRI with EUVIS in the hepatobiliary phase compared to CT for sure. If you can't have an MRI with EUVIS and then look at the hepatobiliary phase, I do think the washout of contrast enhanced ultrasound is probably better than CT for the question of tumor focality. Obviously, we need studies to be able to prove that, but hepatoblastoma is rare, and I'm not sure we're ever going to have the numbers to be able to sort of prove that, if you will. But okay, I was going to move on to go, Jeffrey.
I just have a question for you. Are you exclusively using contrast enhanced ultrasound for liver lesions for characterization, or are you ever using it for following lesions? We've had a couple of scenarios where our oncologists have asked us to use kind of serial contrast ultrasound to follow. In this particular case, I'm thinking of it was a FNH-like lesion, and we did several contrast ultrasounds on the same lesion. Do you ever do that, or do you just use it for characterization and then follow it with probably just grayscale ultrasound?
We have done serial old contrast enhanced ultrasound when we could see the lesion so much better post contrast, like to look at the size of it. But at focal nodular hyperplasia should get bigger, right? We expect them to get bigger, but they don't undergo malignant transformation. So for us, if I'm confident it's a focal nodular hyperplasia, I say that's what it is. And then if they want to follow it, like to look to see if it's a larger lesion and they're worried it's going to eventually cause mass effect or something like that because of the size, not because of malignant degeneration, then we just typically do that without contrast. We just do ultrasound. We definitely do serial ultrasounds for other purposes, though, not necessarily to follow a lesion. Theoretically, I guess if the grayscale appearance of a lesion had changed and you're worried the lesion has undergone malignant degeneration or like bled internally or something like that. Like I'm thinking of hepatocellular adenoma, you know, but we actually haven't done that because in a male, they were going to want to take a suspected adenoma out because those supposedly have such the highest risk of malignant transformation. And then the other ones we like, you know, the risk of them is the likelihood is the risk rather is bleeding. And depending on the subtype we think it is, you know, at a certain size, they'll resect it for the risk of bleeding, not because they're concerned about malignant degeneration. But
Judy, you briefly mentioned that sometimes you'll follow it if the lesion's better seen post-contrast. What if on follow-up, because it was already hard to see on grayscale that you don't see it, you know, like despite really scanning and trying to look for it, do you still give contrast in that setting if you can't really truly target anything?
you mean like on a follow-up grayscale?
Yeah, follow-up grayscale, or even initial, like, you know, they'll be referred for a lesion and then you do your, you know, scout scan or whatever, and you're like, you don't see it. And you still just give contrast in hopes that you'll catch it or just
it depends on the lesion. So the first contrast enhanced ultrasound I ever saw was like clearly a case of artifact. Like what needed to happen was they needed to optimize their imaging, make the lesion go away. And then they should not have done a contrast enhanced ultrasound. Now I will say there have been times that there's a lesion and I think maybe it's mostly the question is this focal fat or is it not, right? And for focal fat, usually I'm pretty confident. I'm like, no, we don't need to do contrast enhanced ultrasound, but I'm usually like, well, let's just be sure. So, you know, I have to be able to see the lesion to do contrast enhanced ultrasound, I feel like. The case I'm thinking of where we could see it so much better post-contrast was actually spleen lesion. So we would do contrast enhanced ultrasound to follow it. I forget the lesion type, but it was, a SANT, a sclerosing, angiomatoid nodular transformation, something like that. And those have a risk of bleeding at a certain size. So we were following the size with contrast enhanced ultrasound. So we could like tell them when it got to whatever, I forget even the size cut off now, but.
Yeah, we've run into similar cases. Like the case I'm thinking of, we had a patient that had a liver iron MRI, had a little liver lesion that we could see. We brought them over to do a contrast ultrasound, and we got the IV in and everything. We were ready to go, and we put the probe down, and you could just not find it at all. So after that, we now have a policy that we make sure we can see it before we put the IV in. But yeah, in those cases, I've kind of wondered the same thing. Like, would we be able to see it after we gave contrast? But I've not gone down that road. If we can't see it with grayscale ultrasound, we don't try to do contrast.
I think the washout is still important because if there's a high concern it's malignant, or like even for problem solving on the MRI, especially with the deposition diseases, when the background liver is weird, the lesions themselves it can be challenging to tell what the lesion itself does. So I like the washout phase. If there's some, clinical concern for malignancy based on either imaging or the patient's risk factors or whatever, the lack of washout to me is reassuring. So we have done a couple of cases where, it's like a cancer predisposition screening. We see something on like a whole body MRI or something like that. And then at ultrasound, usually we can see something, or maybe I hallucinate something pre-contrast, or we find a landmark. Like we just did one the other day where it was like sitting right anterior to the portal vein bifurcation. So we couldn't see the lesion itself very well, but we had a nice landmark that we knew if we could see that during contrast, all phases of contrast, we could see where the lesions should be. And the lack of washout on delayed phase imaging is reassuring to me. Yeah, because the presence of washout is less specific, but the absence of washout. Okay, trauma. Just briefly, because I'll tell you my biases about contrast enhanced ultrasound of trauma later. But this was one of the first cases we did. It was a 14-year-old kid, BMX bike accident with this liver laceration. One of my colleagues questioned if this could be some sort of a vascular malformation, which it clearly is not, but this was when we were trying to grow our practice. The trauma surgeon was like, hey, I remember you talking about this contrast enhanced ultrasound. Could that answer the question? And of course it could definitively answer the question of, this is definitely just a laceration. It's not some sort of a vascular malformation. And just like at CT, the bubbles or the contrast is not going to go where the injury is. A pseudoaneurysm or some sort of active extravasation, you're going to be able to see puddling of contrast either in the vessel or actively pooling out of the vessel. I liked this case because there was also a little hemorrhagic fluid surrounding that adrenal gland, and you can see the little right adrenal gland really well sitting on top of the right kidney, so it's cute. This was a kid for a different reason. So she had skiing accident. Sorry, the thing is blocking the word, so I keep looking at that screen. So she had skiing trauma. We knew she had this splenic laceration from an outside hospital, but then she got transferred to us, mostly for monitoring, and her pain worsened a lot. And so the question was, did her spleen rupture? Does she have some sort of pseudoaneurysm formation? And we did a contrast enhanced ultrasound, and it looked identical to the CT. So, just non-enhancement corresponding to all the areas where there was non-enhancement on the CT. I'm going to tell you my bias about contrast enhanced ultrasound in the setting of trauma now. And one of the huge, and I think should not be underestimated limitations is because its contrast agents don't have renal excretion, you cannot add the collecting system injury to renal injury for the AAST grading of renal lacerations. So when do you guys, and when, in what circumstances do you guys do contrast enhanced ultrasound for trauma?
My answer is easy. We just do not do it. And usually it's a staffing issue, probably, because only very few of us do contrast enhanced ultrasound. And so it's just not going to be available for traumatic cases.
Yeah, we're similar. We actually have a whole protocol for it, but we've never actually scanned any of them. And it's kind of the same issues I mentioned, the same as high tweets, kind of staffing. If we're just doing these weekday daytime hours and there's a trauma that comes in at overnight or on the weekend or something, like it's kind of the same thing I learned from kind of implementing our Volvulus protocol was you have to really be consistent about when and how you offer things for them to really kind of become embedded in how your institution kind of thinks about these things. So, I mean, in Colorado Springs, we only have one CT. So if our CT goes down, we don't have any other option to scan trauma patients. So we either have to go on divert or we have to, come up with some other mechanism of trying to scan these patients. So I really tried to do it for specifically in Colorado Springs, just to have an alternative for those cases when our CT goes down. But really just all those kind of logistical hurdles are really just kind of too much for us to overcome, and the inconsistency of when we can offer this exam.
Yeah. I find our trauma surgeons less and less do CT. There's a clinical effectiveness guideline that they use, and for hemodynamic stability, they will just serially monitor them. My big bias is when we do these contrast enhanced ultrasounds for trauma evaluation, we were part of a multi-site study, and I feel bad scanning a patient who has a seatbelt sign, they're bruised, and as I'm pushing to be able to see, like we're actively causing pain. So I'm just like, man, CT is like pretty quick. You see everything. You get the renal collecting system injury question answered if you do delayed phase imaging. So I only want to do contrast enhanced ultrasound in traumatic settings for problem solving. I don't know. I feel bad pushing on a kid who has a bunch of abdominal bruising.
Yeah, and I thought this might have, we occasionally have, those ones that have very high degree of suspicion for some traumatic injury, like those, I don't think we'll ever get away from doing CT in those, but the ones that have that kind of low to moderate mechanism of injury and they want to do some kind of imaging, like oftentimes they'll just order a grayscale ultrasound, which we know has very poor
Yeah.
sensitivity. And I don't know. I've thought about, in those scenarios where they want to do some kind of imaging, but they haven't met the threshold that they feel like they need a CT. I thought
Yeah.
it have some applications in that scenario, but yeah, same thing. We're not quite there yet.
I think that's a great idea. Where the pretest probability is lower. We got asked to do, it was a case of suspected non-accidental trauma where the CT read was a little bit confusing, or I guess the CT picture, not just the read, was confusing. And I really did not want to be involved in any sort of lawsuit with contrast enhanced ultrasound, but anyway, okay. The other topic I wanted to, I guess, briefly touch on, since we only have 10 minutes, is the other area that we do, our volume is almost as big as our liver lesion evaluation volume is in our intensive care units. So we have our pediatric intensive care unit, our CICU, and then we have our NICU. And there are a ton of advantages of contrast enhanced ultrasound in this patient population who often have renal failure issues. They often have transportation issues. The nurses do not want to pack up all of that stuff to come to the imaging suite. Even if you have a portable like CT or MRI, they have to move the patient at least a little bit. So just some examples that we've used clinically. So this was a 15-year-old pre-heart transplant patient. And I'm never going to forget this case because the heart transplant surgeon was like, if this is pneumonia, he does not get a heart. If it's just atelectasis, he gets a heart. So it's you that's going to decide, basically. And I'm like, oh God, no pressure. But this was a beautiful case because we could see that there was some consolidated lung with some thick, nasty, like in the pleural space gunk. You can't really see the hemidiaphragm that well, but the spleen. So this is the kind of a oblique sag view. And at contrast enhanced ultrasound, all of that gunk, of course, in the pleural space did not enhance, but the lung enhanced beautifully. So it was just all atelectasis with, for whatever reason, hemorrhagic, gunky, like pleural fluid. So the surgeon scooped all of that out, he said, and this patient did great post-heart transplant. So no pressure. Another example, this was a 4-week-old who had unfortunately late group B strep infection. And you can tell this is a very abnormal head ultrasound with, subcortical, intraparenchymal, probably some subpeel abnormal hyperechoic areas. But over time, as we're following this patient, we couldn't get great fill in the superior dural venous sinus. And there was some like echogenic stuff kind of peripheral to the dural venous sinus. And so the question was, well, is this thrombus? Do we need to now anticoagulate this patient in addition to all of the other stuff that they're doing to support this baby? And at contrast enhanced ultrasound, there was beautiful enhancement of that superior sagittal dural venous sinus. So this was a nice problem solving for them because they didn't want to, this baby was critically ill. They didn't want to move him. And they also didn't want to unnecessarily anticoagulate him. I think I might stop there, and that way we can answer questions that are left over in the chat. What do you guys think?
I don't have any additional questions in my chat box.
I just have one additional, if you can take a moment to discuss that, was about what our experiences are. I know we briefly talked about allergic reactions earlier. What have your kind of real world experiences been about? Have you had any allergic reactions, or how have you kind of approached that? We actually haven't had any so far.
I'm gonna knock on wood. We have not either. We always have our contrast reaction kit in the room with us. I had one kid who had, I think, a headache like on their way home. So who knows if that was even related or not. What I have seen a couple of times, hold on, because at the end of this PowerPoint, actually, I gave an example of it. Persistent heterogeneous hepatic enhancement. I've seen this like 3 times now. Can you still see my screen? Is it still sharing?
Yeah.
Where you give the contrast, there's normal arterial vascularity of the lesion in the liver, but then the contrast just chills with this kind of weirdo appearance. On the grayscale, you can actually see the bubbles like in the hepatic parenchyma itself. So we've seen this, I think, 2 or 3 times now, which makes lesion evaluation challenging because the washout is messed up. So it's been pretty described. I'm not sure exactly what is happening, but they think there's some sort of, I'm not sure why that's on its side like that. They think there's some sort of phagocytosis of hepatocytes of the contrast agent, and then they get stuck in the parenchyma, giving this weirdo appearance. But that's the only reaction I have had. Have you guys seen this?
I have not seen that. That's definitely a good thing to be aware of, though.
Yeah, you didn't mess up. It's like, it's just one of those things that can happen.
So do you usually see it in a specific patient population? I mean, with your enterocolitis, like I'm thinking,
Yeah, so
this
this patient did have necrotizing enterocolitis, and I think in the literature, the examples I've seen were some sort of bowel issue. Yeah, I can't remember exactly. I'll show this these references again, and you guys can go look at them again. I've seen it with both of our cases where this kid actually I don't think had necrotizing enterocolitis. It was clinically suspected because his bowel looked really pretty normal at ultrasound, like no complex fluid. We didn't see pneumatosis, but he definitely had some like ileus type of a picture, not normal bowel. But anyway.
All right, then a couple more brain ultrasound questions. First, is there any contraindication for brain ultrasound in ultra low weight preemies?
No, I could talk all day long about brain contrast enhanced ultrasound, but the safety profile is identical to other indications. You're just putting your transducer somewhere else. The one thing I will mention with concern for brain contrast enhanced ultrasound, so as these bubbles are expanding and contracting, if you purposefully rupture them, there is some theoretical risk to local structures. So it's called sonoporation. And so I don't ever increase my mechanical index once I have contrast on board. So I don't do any sort of flash, like high mechanical index imaging to purposely destroy the bubbles, because I don't want to cause any damage whatsoever to the tiny super sensitive structures in the brain. But like the prior indication of shunting, so like all preemies are going to have a PDA. I don't think that's a concern. We can go over other safety stuff, but yeah, there's a lot of caveats.
Then another question about our quantification discussion. Are either of you using absolute values to determine severity of disease for bowel and Crohn's disease?
No, I'm not using any absolute values. Most of the time I'm using the curve and more so as a relativity. So I don't have any examples on hand to just pull out like Judy, but maybe I'll start like clipping them and collecting them. But yeah, so you'll see, depending on what you're comparing it to, sometimes if I'm lucky, it'll be next to a vessel. And so I'll place like the two ROIs, and then you can kind of see if one enhances or not relative to the vascular structures. Similar like you would do with a liver lesion, you put it on a normal parenchyma versus the lesion itself and just kind of see how it enhances. So I just use the two, like the more normal-ish and then versus the abnormality that I'm comparing. And then I kind of like see quantitatively like how those curves appear. But I don't have like a specific cutoff because the cutoffs themselves change depending on how fast you inject, like, what may occur within the tubing. So I feel like there's a little bit of variability with that. So I just mainly the curves themselves.
Yeah, I know in the adult world, they compare like at disease specifically in the setting of inflammatory bowel disease, they compare the time intensity curve at presentation, and then 6 weeks, I think, is the most common time point following therapy to see the change over time. There's not like absolute cutoff values that I'm aware of, and at least with the software on my machine, the peak enhancement value is kind of meaningless. Like the rate of enhancement is more important. Like it gives me this, like the peak enhancement will be some weird negative decibel value, and depending where I put my ROI, that vessel can change wildly when it like looks like it shouldn't change that much. So I'm skeptical of, at least on my machines, the TIC values. The comparison over time, I feel like is where it's at.
So kind of using each patient as their own internal control and following them over time is more helpful than absolute numbers, you feel like?
Yes.
All
Or
right.
if you have an internal control on that patient, like Kai was saying, the vessel adjacent to it. Yeah.
Yeah. And we usually do it more so for like comparison over time, like Judy said, you know, like we diagnose it and then following treatment, like this is how it looks, or did it improve? And actually our GI team sometimes, actually most of the time, even do their own bowel ultrasound. You know, like they measure their own thickness and stuff like that. And sometimes would only refer for problem solving, or if they want to take them to surgery. So it's kind of like an inconsistent service. So I don't have like a set standard protocol yet.
We will compare for brain imaging, we will compare like relative enhancement for different regions of the brain, like deep green nuclei versus the supratentorial white matter, like just on the same image. But again, that's like a relative enhancement, not an absolute number.
And I don't know if it's on every single machine, but I know on ours, I was told that you can even do, there's like a button that you push where it actually helps with tracking. So you can kind of like let the machine automatically try to track, because obviously there's going to be motion associated. So I found that to be helpful because it does try to attempt to stay on the lesion or the region of interest.
Same. Yeah.